Welcome to the deep dive. Today we're getting into something really fundamental, deeply personal, but also critical on a global scale.
Absolutely. We're kind of pulling back the curtain on a health challenge that, well, it touches the very start of life, doesn't it? Bringing life into the world.
Exactly. And our mission here is to uncover what's being done, what needs to be done to make that experience as safe as possible.
And it might sound quite stark, the topic itself, maternal mortality.
Hmm.
But the story, actually, it's one of incredible progress alongside these persistent challenges and some really inspiring solutions, too.
Right. So our deep dive is focused squarely on maternal mortality in India. We really want to unpack the journey India's been on, understand why experiences can be so different depending on where you are in the country.
Yeah, those regional differences are huge.
Look at the root causes, and importantly, shine a light on what's actually working, what's saving lives.
And the fascinating thing right off the bat is that overall trend. It's positive. There's been a remarkable decline in maternal deaths in India recently. So it's not all bad news, not by a long shot.
Okay, let's start there then. When we talk about maternal mortality, what exactly does that mean? It's quite a specific definition, isn't it?
It is, yeah. It's defined as the death of a woman while pregnant or within 42 days after the end of the pregnancy. And crucially, it has to be from a cause related to or made worse by the pregnancy or its management.
So not like accidental causes.
Exactly. Excludes accidents or incidental causes. It's really focused on the health risks directly tied to pregnancy and childbirth. It's a key indicator, really, of how well a health system is supporting mothers.
Got it. And the national picture in India, the numbers look, well, pretty encouraging lately.
They really do show momentum. The latest figures for 2019 to 2021 put India's maternal mortality ratio, the MMR, at 93 deaths per 100,000 live births.
93. And that's down from?
Down from 103 in the previous block, 2017-19, and significantly down from 130 back in 2014-16.
Wow.
Yeah, that's a 37-point drop in a relatively short space of time. That's a massive public health win.
That really is a huge shift. How does that stack up globally? Are we talking about meeting international goals here?
Well, it brings India much closer to the Sustainable Development Goal target. The SDG target is an MMR below 70 by 2030.
Okay, so 93 is good progress, but still a way off from 70.
Precisely. We're moving in the right direction, definitely doing better than many developing nations where the MMR can still be, tragically high, sometimes in the hundreds or even thousands. But there's still that critical journey ahead to hit that global goal.
And just for context, what are developed nations looking at?
Oh, some are down in the single digits. The UK, for example, is around 8. So it really shows the spectrum, right? India's made huge strides, but there's still ground to cover to reach those levels.
Okay, this is where it gets, well, complicated. Because that national average of 93, while good, it hides some massive variations, doesn't it, when you look state by state?
Oh, absolutely. It's really a tale of two Indias, sometimes even within the same region. The lived experience for a pregnant woman can be dramatically different based purely on geography.
So how does that happen? How can one country have such different outcomes?
Well, take Kerala. Down in the south, their MMR is incredibly low. It's 20.
20? Wow. That's comparable to developed countries.
Exactly. It rivals many Western nations. It's proof, really, of what's possible within India itself. And it wasn't an accident. It's built on decades of consistent investment in public health, education, female literacy, social welfare. It creates a really strong foundation.
Decades of work paying off. That's incredible. But then you contrast that sharply with other states.
And the contrast is stark. You look at states like Assam up in the northeast, its MMR is 167. Madhya Pradesh in central India is at 175. Uttar Pradesh, a huge state in the north. Latest understanding puts it around 1 to 51, though it was higher before.
Gosh, 175 compared to 20, the difference is just huge.
It's shocking, frankly. It highlights these deep, deep regional inequities in access to care, infrastructure, everything.
And is there a pattern, like a north-south divide?
There's definitely a general trend there. The southern states, Karnataka is at 63, Andhra Pradesh 46, Telangana 45, Tamil Nadu 49. They consistently perform much better than many northern states and what are called the Empowered Action Group states, the EAG states.
Right, the EAG states. Remind us what those are.
Yeah, they're a group of states, mostly in the northern and central belts, Bihar, Jharkhand, Madhya Pradesh, Chhattisgarh, Odisha, Rajasthan, Uttar Pradesh, Uttarakhand, and also Assam. They were identified years ago because they historically lagged behind on various health and development indicators. So they've been a focus for national health programs because they face, some pretty complex challenges.
So the difference isn't just numbers. You used an analogy before, like cooking.
Yeah, it's like having the same basic ingredients, national guidelines, some level of funding, but ending up with wildly different results. The recipe for maternal health, how it's actually implemented on the ground, the local infrastructure, the healthcare access, even social factors, it all leads to vastly different outcomes for mothers and their families.
That really brings it home. So let's keep maybe two hypothetical women in mind. Say Priya in a remote village in Uttar Pradesh and Sarah living in Kerala. Their journeys help illustrate the why. So what are the core reasons? What are these systemic challenges? You mentioned the three delays.
That's a really critical concept. Research points to these three main delays, and they're often linked, creating this dangerous sort of cascade.
Yeah.
The first is the delay in deciding to seek care.
Okay, what does that involve?
It's that initial hurdle, maybe a lack of awareness about danger signs during pregnancy or childbirth, or cultural beliefs might prioritize traditional practices or home remedies first. Financial worries can also play a big part, the cost of transport, the potential cost of treatment, lost wages. Families might hesitate.
It's like ignoring your car's check engine light, hoping it'll just go away.
Exactly like that. But the stakes here are infinitely higher. Life or death, literally.
Right.
So Priya's journey might start with this delay, losing critical time.
Okay, so that's the first delay. What's the second?
The second is the delay in transportation, getting to a health facility. This is a huge logistical challenge, especially in rural, remote, or, say, tribal areas. Think dense forests, hilly terrain, villages far from paved roads, maybe even islands.
Right.
Getting transport, especially emergency transport, can be incredibly difficult, sometimes impossible. It's like trying to hail a cab during Mumbai's rush hour when you absolutely have to get somewhere urgently. Every single minute counts in an obstetric emergency. Priya could face huge struggles here.
So deciding to go is one thing, actually getting there is another, and then the third delay.
The third is the delay in receiving adequate and appropriate care once the woman reaches a health facility.
So even getting there isn't the end of the struggle.
Sadly, no. The facility itself might face major issues. We see severe shortages of specialists like obstetricians or anesthetists. One figure points to like 66% vacancies for specialists in community health centers or CHCs.
And CHCs are supposed to be?
They're meant to be the first referral units, FRUs. The places equipped to handle basic emergency obstetric care, like C-sections or blood transfusions, before needing to go to a bigger district hospital. But if the specialists aren't there,
Then it's just a building.
pretty much, or they might lack essential resources like a functioning blood bank or reliable electricity or critical medicines. It's like arriving at a restaurant, you see tables, but there's no chef in the kitchen. The potential is there, but the actual life-saving care can't be delivered. This is often where Priya's situation could become tragic, despite getting to a facility.
And these delays, they happen while serious medical issues might be unfolding. What are the main medical complications that become fatal when combined with these delays?
Well, the biggest killers, especially when care is delayed, are things like postpartum hemorrhage, that's severe bleeding after childbirth. It needs immediate, skilled management. Think of it like a tap that just won't turn off.
Okay.
Then there's obstructed labor, where the baby physically can't be delivered vaginally. Again, needs timely intervention, often a C-section, like a complete traffic jam, but for the baby.
Right.
Hypertensive disorders are another major one. Preeclampsia, eclampsia. Dangerously high blood pressure during pregnancy. It can escalate very quickly, like a pressure cooker about to blow.
Yeah.
Needs expert monitoring and management.
Very.
And sepsis, severe infection, often linked to unhygienic delivery practices, maybe during a home birth, without proper precautions. It's like letting dirt get into an open wound. Plus, in some areas, especially those EAG states, associated illnesses like malaria can complicate pregnancy and increase risk significantly.
It's a really challenging picture.
Yeah.
But as you said, it's not just about the problems. There are proven solutions, things that are working. What's making a difference on the ground?
Absolutely. And these aren't just theories, they're evidence-based. Two of the most fundamental are early pregnancy registration and regular antenatal care visits, getting women into the system early, monitoring them throughout the pregnancy.
Like servicing your car before a long trip, catching problems early.
Exactly. It allows healthcare workers to identify risks, maybe high blood pressure or diabetes or anemia, and manage them before they become emergencies during labor or delivery.
And the other big push is getting women to deliver in hospitals.
Yes, promoting institutional deliveries, making sure birth happens in a health facility with skilled attendants present rather than at home, especially without skilled help. It's about having access to emergency care immediately if needed. Choosing the well-equipped hospital over a potentially risky situation at home. This is a huge factor in Sarah's, our hypothetical Kerala woman's, safe delivery.
So those are key interventions. What about bigger picture, systemic improvements?
The National Health Mission, the NHM, is the main government program driving a lot of this. It supports things like strengthening facilities, training workers, and importantly, it mandates reporting and auditing of maternal deaths.
Audits, like quality control.
Kind of, yeah.
Oh.
Maternal Death Surveillance and Response, MDSR. It's about investigating why each death happened to identify system failures and prevent future ones, learning from tragedies.
Which brings us back to Kerala, that low MMR of 20. What's their secret sauce? What's in their playbook?
Kerala's approach is really multifaceted. One key thing is their long-standing system of confidential review of maternal deaths, started way back by a Dr. V.P. Paley. They don't just count deaths. They meticulously investigate every single one to understand the clinical and systemic factors.
So it's really about deep learning from every loss.
Absolutely. It's ingrained. It feeds back into training, protocols, resource allocation. It's created this culture of accountability and continuous improvement that's quite remarkable. They also focus on specific medical practices, like protocols for managing hemorrhage, using things like uterine artery clamps, or effectively handling rare but dangerous conditions like amniotic fluid embolism. They have a very clear, evidence-based approach.
That confidential review sounds crucial. How does that actually change things on the ground? Does it just point fingers?
No, the key is that it's confidential and focused on systems, not individual blame.
Ah.
A multidisciplinary team reviews the case notes, talks to providers, looks at the whole chain of events. They identify where the system failed, maybe a delay in referral, lack of blood, a gap in training. These findings then directly inform changes, updating clinical guidelines, running specific training modules, advocating for better equipment or staffing at certain facilities. It creates a constant feedback loop for improvement.
So it builds a stronger, more resilient system over time. And technology must be playing a part too, especially reaching remote areas.
Definitely. Tech is becoming a game changer. Think mobile health apps for women and families, providing information on nutrition, danger signs, appointment reminders. Telemedicine is huge, connecting rural health workers or even patients directly with specialists in cities for consultations.
Bringing expertise remotely.
Exactly. Electronic health records are helping too, making sure a woman's history is available wherever she seeks care, improving coordination. And then there's really innovative stuff, like using drones to deliver blood products or essential medicines to cut off areas, bypassing difficult terrain.
Drones, wow.
Yeah, it's like assembling a superhero team. Each tech tool has its own power to bridge a specific gap, especially for that last-mile delivery of care.
And underpinning all of this is the community involvement, right? People like the ASA workers.
Absolutely critical. The ASHA's accredited social health activists are the front line. They're local women, trained to be that link between the community and the health system. They visit homes, track pregnancies, educate families on danger signs, encourage antenatal care and institutional delivery, accompany women to facilities sometimes. They build trust.
They're the eyes and ears on the ground.
And the trusted voice, often. They empower the community from within. Hugely important.
So let's bring it back to Priya in Uttar Pradesh and Sarah in Kerala. Their imagined stories really crystallize the impact of all these factors, don't they?
They really do. Picture Priya. She's pregnant, maybe in that remote UP village. Complications start. First, there's the delay deciding, is this serious? Can we afford it? Then the struggle for transport, maybe hours waiting, a long, bumpy journey. If she finally reaches a CHC, perhaps the specialist isn't there or the blood bank is empty, the delays stack up, and tragically, it leads to the worst outcome.
Such a preventable tragedy often.
Often, yes. Now contrast that with Sarah in Kerala. She likely registered her pregnancy early. An ASHA worker or local nurse visited, gave clear advice. When she goes into labor or if a complication arises, there's a reliable ambulance service. She reaches a well-staffed, well-equipped hospital. Doctors, nurses, resources are available immediately. She delivers safely, goes home with her healthy baby.
The difference is stark. It's not just numbers, it's lives, it's families.
Exactly. It highlights that the difference between life and death often comes down to access. Access to information, transport, skilled care, resources. It's like comparing, driving a modern car with GPS and safety features versus trying to navigate a dangerous road on a broken bicycle. The disparity in the journey and the likely outcome is massive. But Sarah's story shows what is achievable.
So looking ahead, what needs to happen? What's the path forward to bridge this gap?
Well, policy is key. Consistent, adequate funding is non-negotiable. We need to keep strengthening infrastructure, ensuring primary health centers and CHCs are truly functional 24/7, especially for deliveries, with guaranteed power, water, staff, and supplies.
And the people, the healthcare workers.
Absolutely crucial. Investing in training, but also creating incentives for skilled workers, doctors, nurses, midwives, anesthetists to actually work and stay in rural and underserved areas. That's a huge challenge. And of course, keep embracing technology to improve access and efficiency.
And learning from the successes like Kerala.
Yes, understanding how Kerala achieved what it did, that mix of health system strengthening, education, social development, and that meticulous review process, and fostering that strong community involvement everywhere, building trust between people and the health system.
The ultimate aim is pretty clear, isn't it?
It's profound, really, ensuring no mother dies while giving life. It sounds simple, but achieving it requires this complex, sustained effort. It's a fundamental measure of our progress, our society.
So we've covered a lot today, the big picture of progress in India on maternal mortality, but also those stark, persistent gaps between states. We've looked at the why, those critical delays, the medical issues, and crucially, the solutions that are working, from policy down to community health workers and technology.
It's a complex tapestry, definitely. Progress and challenges woven together. But hopefully you get a sense of both the scale of the issue and the real potential for change.
And as we close out this deep dive, maybe we can leave you with a thought from Mahatma Gandhi. He said, "The true measure of any society can be found in how it treats its most vulnerable members."
Powerful words, and incredibly relevant here. Thinking about pregnant women, especially those in difficult circumstances, as among the most vulnerable.
So perhaps think about what this understanding means for you. Maybe it sparks further curiosity or appreciation for the public health efforts underway.
We hope this deep dive has been valuable. Thanks for joining us.
And we hope you'll continue the journey of deep understanding with us next time.